Hello, and welcome to this pre-recorded presentation hosted by the National Collaborating Center for Infectious Diseases. My name is Harpa Isfeld-Keeley. I'm a project manager with the NCCID. We are knowledge brokers in the area of infectious disease public health, funded by the Public Health Agency of Canada and hosted at the University of Manitoba in Winnipeg. In the AMR theme area of our work, we foster several information exchange events to advance the development of antimicrobial stewardship programs, particularly evidence-based and practical approaches that align with practitioners' needs. As one of those events, today you'll be hearing from Dr. Ganesan Abu offering a presentation entitled Targeting Acute Respiratory Infections in the Outpatient Setting. This presentation will soon be followed up by a live webinar discussion of Dr. Abu's work, as well as other opportunities for advancing antimicrobial stewardship goals through integrated, workflow-oriented strategies. The title of that live webinar discussion is Paths of Least Resistance, Integrating Antimicrobial Stewardship. Please register at any time for the live webinar event by clicking the link you'll see at the top of the page here. We will display the link again at the close of this recording. The registration page contains all details of the event, including the confirmed date. Now I'm going to introduce our speaker today. Dr. Ganesan Abu is an assistant professor at the Department of Family Medicine with the Max Rady College of Medicine at the University of Manitoba. He is also the physician lead with the Antimicrobial Stewardship Committee in Southern Health Santé Sud, a regional health authority in the province of Manitoba. Dr. Abu serves as secretary for the Manitoba College of Family Practice. His current practice involves family medicine, family practice anesthesia, and emergency medicine in the community of Winkler, Manitoba, where he is also the ICU director at Boundary Trails Health Center. Welcome, Ganesan, and I invite you now to begin your presentation.
Well, thank you, Harper, and thank you for inviting me to this webinar on targeting acute respiratory infections in the outpatient setting. My presentation is in two parts, and firstly there will be a short presentation that will provide a general overview of the problem, to discuss what influences inappropriate prescribing and how we can mitigate these factors. In the second part of the webinar, I would like to demonstrate a prototype app that addresses acute respiratory infections. The big picture is very clear. Your resistance is on the rise and new drug discovery is in decline. We can consider this problem in a number of ways. For example, we can consider this in terms of the cost of antimicrobial prescriptions or the number of prescriptions per 1,000 population. And we can also look at the disease types that account for most inappropriate prescriptions. If we consider the cost of antibiotics prescribed, this slide reveals that 62% of all antibiotic prescriptions come from community outpatient settings. And about 80 to 90% of antibiotics are prescribed either in the ER or in acute care centers. If one looks at the number of prescriptions per 1,000 population, we notice that in Canada we sit at around 500 prescriptions per 1,000 population. This means that in any 1 year, every second person in Canada will potentially receive an antibiotic. How do we compare when we look at ourselves against other OECD countries? Now, Canada would seem to be in a favorable position. However, when you look at the real numbers, we quite at some distance from countries like Sweden and Netherlands, who have a prescribing rate of only 300 per thousand population. Now, if we look at the North American numbers, 30% of our prescriptions for antimicrobials are inappropriate. And this translates to 50 million inappropriate prescriptions every year. And when considering unnecessary antibiotics by disease type, we notice that, for example, if we look at upper respiratory infections, if we look at ear infections, of the 23 million prescriptions for ear infections, 30% were inappropriate. Similarly, the rate for inappropriate prescriptions are about 50% for acute sore throat and sinusitis. The goal is clear, and that is to reduce inappropriate prescribing by at least 50% for acute respiratory infections. In order to optimally address this goal, we need to look at the reasons why prescribers prescribe inappropriately. And there are basically two reasons. One is a reason that concerns a knowledge gap. So prescribers may be unaware of the guidelines that exist amongst a myriad of other competing guidelines in cardiology or respiratory disease or cancer care. Some may find the guidelines too complicated, or the guideline may not be readily accessible. The second area is one that concerns behavioral reasons. Prescribers feel that perhaps other people are the cause of the problem. They don't really see themselves as being part of the problem. Some physicians or prescribers note that their population or their patients are somewhat unique and justifies a different set of rules. And lastly, it's difficult for prescribers to focus on the patient to prescribe on an issue which is too far remote from the patient consultation. They are more concerned with the patient that is there in front of them. And antimicrobial resistance is something that occurs in a remote space at some future date. Now, technology can help us by embedding guidelines into the usual physician workflow. And this can help circumvent the barriers of the knowledge gap and some of the behavioral issues. So one may argue that if we're unsure, then it's better to treat with antibiotics to prevent complications. However, the risk of complications is actually very low. One would have to treat 4,000 cases of the cold to prevent one case of bacterial pneumonia. We can safely wait up to 9 days for a throat culture and still not risk the complication of rheumatic heart disease. So we have time to test before we treat. Secondly, one has to also consider the risk associated with prescribing antibiotics. 1 in 1,000 patients will end up in the ER with allergic reactions, diarrhea, or yeast infections. And then there's the scourge of C. diff. 35% of adult and up to 70% of pediatric cases of C. diff are attributed to community antibiotic prescribing. So the risk aspect has to factor into a discussion about antibiotics. Prescribers are also of the opinion that they are very good at predicting which patients are demanding antibiotics. The reality is that we don't have a clue. This study by Strivers et al. In 2003 showed that a parent who suggests a candidate diagnosis is 5 times more likely to walk away with a prescription. Similarly, if a parent challenges a diagnosis, then they are 3 times more likely to get antibiotics. There seems to be a disconnect between patient expectation and what physicians deem is appropriate. What patients really want is an explanation of why an antibiotic was not required, reassurance about complications, and a contingency plan if things do not improve. Lastly, this graph helps us understand that we as physicians lose objectivity just before lunch and at the end of the day. A more objective prescribing tool may help overcome this. Before I demonstrate the prototype app, I would like to quickly summarize how the app addresses some of the issues we've covered. Firstly, it's developed for outpatient prescribing and addresses the bulk of inappropriate prescribing. Secondly, it targets acute respiratory infections, which again account for most inappropriate antimicrobial prescriptions. It tries to address both the knowledge gap as well as some of the behavioral issues. It incorporates a patient discussion tool so that we're all on the same page. It has the ability to print appropriate patient handouts. So if we give antibiotics, you get one type of handout, and if you don't, you get a different type of handout. It has a selling feature in that it automatically creates the physician notes in the SOAP format. Lastly, there's an opportunity for analytics. This is not yet included, but we will work further to incorporate this. I would now like to demonstrate how this app works. And I would like to say that this is a concept tool that is as yet unfinished. It's not fully tested, and your opinions for improvement are welcomed and valued. So firstly, why did we choose the name arias? So just as an aria is the voice of a single opera singer, arias was intended to be the voice for acute respiratory infections. And of course, the title is also an acronym for Acute Respiratory Infections Antibiotic Strategies. We have a physician disclaimer here. I'm not going to go through it, but it states that it's intended for use by healthcare professionals and so forth. We enter the app, and the first screen we see concerns a list of acute respiratory illnesses. Each of these is created on evidence-based Canadian guidelines. At this time, only the acute sinusitis piece is completed. So I'm going to show you a flow through acute sinusitis. Now the workflow mirrors an actual clinical encounter, going through symptoms and signs, making an assessment, and finally considering appropriate management. Unlike a calculator that presents only the information required to calculate a score or reach a clinical decision, our app embeds the guidelines in a way that is objective and non-leading. Now you will notice some of the red flags and this alerts the user to concerning symptoms. Also, at the bottom of the screen, there are some mandatory fields, and this information is absolutely required in order to be compliant with the guidelines. So what I want to do is give you a scenario and then work through that. Let's look at a 34-year-old man who presents with a 5-day history of pain in his sinuses and headache that's made worse by bending forward. He admits to greenish nasal discharge and a blocked nasal passage. His sleep is not disturbed, but his symptoms are constant. His examination reveals a fever of 39 degrees and maxillary sinus tenderness. Now, would you have considered prescribing antibiotics for this patient? I want you to think about that and then compare with what the app finally comes up with. So let's fill the symptom screen. So again, 5-day history of pain in his sinuses, so we'll check that off. He has a greenish nasal discharge and a blocked nasal passage. His symptoms were continually present for 5 days, and the severity is constant. So you can see the app is saying, well, you need to answer all the questions. You need to say how many days there was purulent nasal discharge. And I had forgotten to do that. Let's say 3 days. Okay. So the next screen takes us to the signs. And again, you'll notice the red flags which alert us that something more than just sinusitis may be happening. A fever of 39 and sinus tenderness in the maxillary sinus. That takes us to the third screen page, and this page looks for factors that may influence antibiotic prescribing. So risk factors for antimicrobial resistance, as well as an allergy to potential antibiotics. So we're going to say that none of these apply, so we'll move on to the next screen. And this is the final screen, and the recommendation is against antibiotics, and you can see that is highlighted here that no antibiotics are recommended, but a trial of intranasal corticosteroids is suggested. Now, I'm not sure if any of you disagreed with the recommendation, and you may have a reason to disagree, but we have a section here for accountable justification. So we had asked that if you disagree and you want to prescribe antibiotics regardless, then please check this and tell us why you disagreed. And maybe there was patient pressure, or you disagreed with the recommendation, or you're unsure. You think that this may be a bacterial infection. So you have that option. The next part of this, we find it important, especially so if you're not prescribing antibiotics, to have a discussion with the patient. So we have a discussion tool that's incorporated, and I'm just going to click on that. It opens up a new page, and this has a pictorial with text on the right-hand side. The text is, with time it is anticipated that the physician would kind of learn the process, and you don't really have to read out the text. But briefly, what the pictures show is that the chance that your sinusitis is caused by bacteria is about 2 out of 100. The chance that your infection, even if it is a bacterial infection, will get better without antibiotics is about 99.5%. So almost every case will get better. And then we wanted to show how this balances with the potential for side effects by prescribing an antibiotic. And this clearly reveals that your chance of getting a diarrhea is about 14%. So the next aspect of this is a patient advice sheet. And in this case, there was no antibiotic prescribed. So the patient advice sheet that one could print off and give to the patient will look something like this. Firstly, it shows empathy with the patient by providing information that explains that we understand how the patient feels. But here's the reason why we don't want to prescribe antibiotic. And then alternatives as to what one could do to feel better. So this is similar to a viral prescription. And then the contingency plan. So what do I do if I don't get better? And to address some of the things, like red flags or worsening symptoms. So this advice sheet is appropriate to the recommended treatment. If we were to prescribe antibiotics, then that advice sheet is different. The last aspect of this tool is the clinical notes section. And we can either print the note or copy it to a clipboard. It can be incorporated within an electronic medical record so that it's automatically in the patient note. But it follows the SOAP format, and excuse us, but the O part here should have been lower down. So it needs a little bit more layout change. But it provides the SOAP note, including important negative features as well as the positive features. And this text can be edited if one chooses. And you'll notice in the plan section here, because we open the patient discussion tool, it records that has been done. And if we printed the information sheet, then it also records that. Now, there is a potential to print the antibiotic prescription, if that was required, through the system. But we felt in order to avoid patient identifiers, this app had to stay out in a space that's outside printing a prescription, for example, that requires PIN numbers and patient's name and ID. So within the EMR, that link could be made, but for the time being, we've left it as a standalone app that, for example, in the ER, if you wanted to write a prescription, you could do that, but you still have the best recommendation possible. If you would, I'm going to quickly run you through a scenario where antibiotic would be justifiable. I'm just going to quickly, let's say 5 days. Just going to make sure that the antibiotic is going to be prescribed. Okay, so we didn't put any allergies in, and you'll see now the management recommendation here is for antibiotic, and it recommends that the lowest possible risk of antimicrobial resistant antibiotic is being used. So in this setting where there's no big risk for antimicrobial resistance, amoxicillin is suggested as the first choice. And we do present an alternate in the form of azithromycin or Septra. But the cheapest, simplest drug is the recommended one. And just to show you, the patient advice sheet then changes to mirror the antibiotic prescription and what to look out for and when to seek help. Well, I want to thank you for giving me the opportunity to speak about acute respiratory infections and to demonstrate our app. I again want to say that this is a prototype. I have been working with people on a volunteer basis in the hope that I could pay them for their work if somebody is able to support us in the end.
Thank you, Ganasan, for your presentation and the demonstration of your prototype. It's thought-provoking to have that innovation in place in a prototype form. And we can see the potential win for stewardship, informed practice, but also for physicians in terms of the flow of their practice and ease of use, and ultimately for patients. If our listeners have questions or concrete feedback for Dr. Abu, or would like to share information on other strategies, please join us for the live webinar discussion when we will consider this innovation and other opportunities for integrating AMS in workflow and systems. Please register for the webinar by clicking the link provided. There you'll be given all the details of the event and have an opportunity to suggest your questions for discussion. If you cannot attend the live discussion webinar, please contact NCCID at the email provided, and we can make a copy of that recording also available to you. So thank you, Dr. Abu, for sharing your innovative work with us today, and we'll soon speak with you in our coming webinar.
Thanks, Harper.
Okay, and thank you to all our listeners, and we hope to see you at our live event. Bye-bye.